The first speaker is a pleasure for me to introduce from US, Philadelphia, Gerald Criner, and he will deal with COPD without obstruction.
Good. Thank you, Enrico. These are my disclosures. So let me give some background to this topic. And I think it ends up being important going back to this morning when Weija Wazika was talking about different phenotypes of patients. And I think the phenotype I'm going to be describing to you are people that smoke and what happens to you if you continue to smoke. So as I'm sure is true in the rest of the world, cigarette smoking continues to be a common addiction in the United States. About 49% of adult Americans greater than 45 are current or ex-smokers, and about 19% of the adult population currently smoke. And COPD is traditionally defined by airflow obstruction on spirometry, smoking-associated effects on the lungs, however, also include emphysema, gas trapping, and chronic bronchitis, which may escape airflow obstruction in some cases, especially with earlier manifestations of the disease. And for this symptomatic session that we're having, the symptoms that we're going to be talking about in this patient group, COPD without airflow obstruction, are those that have productive cough, dyspnea, exercise intolerance, and in some patients, when you're older, that might be taken as normal aging, but really in former older smokers, that could be manifestations of disease. And in some cases, spirometry may not be the most sensitive test to diagnose earlier disease or all the forms of lung disease that can occur as a result of prior cigarette smoking. So there could be subclinical or complex forms of smoking-induced lung pathology or mixed phenotypes that aren't really captured by spirometry by itself, especially the spirometric criteria that we use, whether it's a fixed limit of obstruction or a lower limit of normal. Either of those kind of reference tools may be inadequate to diagnose impairment to COPD or identify other smoking-related lung diseases. So Weija showed this earlier this morning, this paper by Alvar and Lang and Organ and Bart, looking at different patient populations and looking at the trajectory of lung function decline over one's life until you develop COPD, here shown at the bottom from the red and the black line. But you can see there's different ways to get there, whether you had normal lung development and then smoke or had environmental exposure and then lost a lot of lung function over your life, or whether you never really had totally developed lungs to begin with from some childhood disorders or really just from poor lung maturation and end up at that same level in your middle to advanced years. Well, if you look at the rate of decline in these patient groups, the one that's on the black line has a 27 ml per year rate of decline, but the patient group that's above this 80% line in the red has a rate of decline that's 53 mLs per year, much greater rapid rate of decline, or more rapid rate of decline. So if we took patients that were here in this red above this dashed line, where we usually consider to be the reference point for airflow obstruction, could we detect subjects in this group sooner and end up altering the trajectory of their disease throughout their life so they don't end up with COPD at a later stage? Well, one of the many trials that are looking at that right now is the COPD gene program, which is a multi-center trial in the U.S. of 17 centers looking at non-Hispanic whites and African Americans to highlight the genetic diversity using CT scanning, clinical demographic data, as well as genomics to develop the different phenotypic expressions of cigarette smoke exposure. So it's a HRCT that's done repeatedly, as well as physiology that's done over the period of time. I'm going to show you some data from that. This is the gestalt of 10,800 subjects looking at their FEV1 to FVC ratio on the y-axis, and their FEV1 is predicted on the x-axis. And you can see the normal definitions or the distribution of the population with gold 1 and gold 2 to 4. And then the gold U, which you could debate what does that mean. That's now changed to Another term, preserved ratio with impaired spirometry, and then this normal population, or quote normal population in the top right corner, that I'm going to spend the bulk of my time. So let's look first at this PRISM group, or the gold U. And what was found in that group that had an FEV1 that's less than 80% of predicted, but FEV1 to FVC ratio greater than 70%, they're not exactly normal. These patients overall, or subjects, some of them were not patients, tend to be African American, tend to be percentage of current smokers, or greater percentage of current smokers. They're less obstructed, they have less emphysema, but they have more metabolic diseases, such as obesity, diabetes, and hypertension in that group overall, that may account for why they have a reduction in the FEV1 to begin with that's less than 80% of predicted. So let's look at this group here. This group that's greater than 80% of predicted with an FEV1 to FVC ratio greater than 70%. And are these subjects really normal? Or do they have symptoms or radiologic findings consistent, I wouldn't say with COPD, because that's not really the definition, but do they have manifestations of structural change or clinical symptomatology that's consistent with cigarette smoke or environmental smoke exposure? So a paper was recently published this year from the COPD gene cohort. This was Liz Reagan was the first author. This looked at individuals from COPD gene. This is published in the Archives of JAMA Internal Medicine. This looked at individuals who were in COPD gene that had spirometry, HRCT, 6-minute walk, and completed questionnaires. And the purpose of this analysis was to identify the clinical and radiographic evidence of smoke-related disease in a cohort of current and former smokers who weren't obstructed. And they labeled these as gold 0. You could argue with that nomenclature since they really don't meet the criteria, but they labeled them for the paper gold 0. And as you can see in COPD gene, that's more than 40% of the group overall who meet this criteria of not having spirometric evidence of airways obstruction who were followed for a period of 5 years. You can see the other distribution of gold 1 and 2 in normals. So let's talk a little bit about the baseline demographics of this group. The gold 0 in this case is the group that's in red. And as you can see, that this patient group compared to age-matched controls tended to be somewhat younger. They tended to be more male. They tended to be more non-Hispanic whites. They tended to be much more likely to be current smokers. Over 50%, almost 60% of the patient population in this gold 0 group were still currently smoking. They tended overall to have less pack years of smoking, maybe because they were younger. They tended to be a little bit more overweight. They had a higher BMI, and they tended to be more educated. Not as educated as the ones who never smoked, but more educated than the ones with gold 2 to 4, the ones who vote for Donald Trump. So they tended to be a little bit more educated. If you look at the lung function in 6-minute walk distance, as you can see by definition, this gold 0 group didn't have much in the way of impaired physiology, but slightly less than what the normal age-matched cohort did. And they also didn't walk as far in 6-minute walk tests. They were equivalent to gold stage 1 group, but more walk distance than golds 2 to 4, but less than with the never smoker group. If you looked at quality of life and comorbidities, you start to find some interesting things. If you look at this gold 0 group, again shown in the red bars, that they tended to have a higher SGRQ, more quality of life disease-specific impairment than compared to ones that were age-matched controls. Not as severe as in the patients who are gold 2 to 4, but about 20% of the patients still had an elevation in their SGRQ score compared to the normal group. They also tended to have greater incidence of comorbidities in the gold 0 group. They tended to have more coronary artery disease. They tended to have more diabetes than the age-matched controls that had never smoked. And they didn't die so much from lung cancer because probably their pack years of history of smoking, they weren't as old, but they definitely had more metabolic disease than the age-matched controls. If you looked at this group overall and look at their other symptoms, they were more likely to have chronic bronchitis, 12% compared to the never smokers that was 0%, almost the same as gold 1. They were more likely to have a hospitalization for COPD about 3% of the time, same as gold 1. and their SGRQ 6-minute walk and breathlessness score was higher than what we would have seen with normal controls overall. Importantly, they had structural evidence. About 26% of the time on CT scan, they either had emphysema more than 5%, or they had gas trapping greater than 20% in 15% of the population. So if you add up these different categories of abnormality, both by clinical symptoms or structural impairment or 6-minute walk distance, about half the cohort, 50% had one of these impairments, and about several of this group, about 3 of these, about 50%, get my numbers mixed up, 20% of the group had multiple impairments overall, 3 or greater. If you looked at medication use, sometimes we go back and we look at guidelines, how well physicians and patients adhere to guidelines, and then we see that there's a separation. Well, maybe this is a clue why, where patients are getting medications that don't even have a gold grade for symptoms. And you can see here that 20% of this patient population, gold 0, were using some respiratory medication. About 20% almost were using a LABA or a SABA. About 10% were using an inhaled corticosteroid, and about 8% were using a LAMA with a SAMA, and about 2% of the population was using chronic oral steroids, a therapy that none of us recommend to use in patients with COPD. So about 20% of this group overall was using common respiratory medications that are reserved mainly for patients with more severe airflow obstruction. If we look at the patients of this group who were using respiratory medications, who were they? They were the ones that are more symptomatic, either by 6-minute walk tests or had chronic bronchitis or had hospitalization for COPD. And you can see these numbers overall, they're about double what they would be in the ones who were not using any medications at all. And finally, if you look at structural abnormalities, these patients were more likely to have evidence of airway wall thickness and a greater percentage of emphysema. So what are the structural abnormalities that's seen in this patient cohort? This is a companion paper that was published from the same cohort in a journal of COPD Foundation. And some of the things we found, like on the left side where the arrows show some evidence of paraseptal emphysema, or on the right side some evidence of central lobular nodules. Some extrathoracic manifestations were also seen, such as eventration of the diaphragm shown here to the left, or evidence of kyphosis shown to the right, which could result in the FEV1 being less than 80% of predicted. And if you looked overall, there was multiple regression that was done that showed imaging features that were more common in this group, which include evidence of bronchial wall thickening, bronchiectasis, central lobular nodules, and evidence of gas trapping with mosaic attenuation overall. One of the other common features of this group is this non-obstructive group, whether they have evidence of chronic bronchitis or not. And this was a publication by Carlos Martinez, again from the COPD gene, that was published in Respiratory Medicine also this past year. And the group that was found to have chronic bronchitis wasn't too much dissimilar from the group overall, except the ones who were more likely to have it compared to those who did not have chronic bronchitis tended to be younger. They tended to be more overweight. They also tended to be current smokers. They had dusty jobs or were exposed to fumes on their job. And again, they were more likely to have hypertension, gastroesophageal reflux, and diabetes. They were also tended to be more breathless by MRC scoring, and they were more likely to have a history of pneumonia in the past. And once again, with medication use, there was a higher medication use with SABA, LABAs, and LAMAs in that group overall. And once again, quality of life was more impaired. These patients had a higher SGRQ and a lower SF36. When we look at this group with chronic bronchitis overall, they had more nasal or allergic symptoms, ocular and upper airway. They more likely had a COPD diagnosis, used more medications, and overall their quality of life, as I mentioned before, was more impaired. And if you looked at point estimates overall, these patients were more likely with chronic bronchitis to have impairment in quality of life and functional status overall. In another cohort in the United States that's marrying more objective monitors, and this data was published in, or was presented by Prescott Woodruff at the ATS last year, but some of this data will be in a New England Journal of Medicine publication in the next couple months. It shows similar things, that patients, if you look at symptoms who are smokers, who have an FEV1 greater than FVC greater than 70%, they'll have a higher CAT score. And you can see in this group over here in the middle, the nature of their symptoms. They'll have more phlegm, they'll have more shortness of breath, they'll have more lack of energy, they'll have more problems with their sleep, and they'll have more cough overall. This patient group also will have a lower 6-minute walk distance, and there'll be a proportion overall that will be using having annualized exacerbation rates that may be as high as 20%. And overall, if you look at imaging, similar to what the COPD gene study showed, these patients who are not obstructed, who have symptoms, who are current smokers, will end up having a more higher degree of lower lung attenuation units or tendency for emphysema, and they'll have more airway wall thickness. So this data is parallel in a sense from two populations that suggest that there are structural features and clinical symptoms without presence of airflow obstruction that are important features that we would consider early manifestations of disease. So is any of this new? In some respects, it's clarification of data that was published close to 30 to 40 years ago. This is data by Dennis Niewander, who in 1979 in New England Journal of Medicine looked at healthy smokers and compared that to controls. And he was able to get biopsies from these individuals that had lung biopsies for other reasons. And he found evidence of respiratory bronchiolitis in all of these subjects. And you can see the manifestations here that he showed for the pathologic features that went along with the abnormalities that he found on the biopsies of these patients. There was data by Remy Jardin in thoracic radiology in 1993 that took healthy smokers and compared that to ex-smokers. And he looked at the patient's symptoms, and they were very similar to the ones I just described to you in these two cohorts from COPD gene and spiromics of having sputum production, dyspnea, and wheezing. And then Remy Jardin also looked at the CT scans at that time over 25 years ago now, and he showed similar things with parenchymal micronodules, evidence of ground glass attenuation, bronchial thickening overall, and subpleural micronodules. And some of these individuals had multiple of these findings overall. So what does this mean? Well, I think overall we can say, and I think there's been several long history of this, both with radiographic imaging, clinical history, demographics, as well as histopathology, that COPD in patients without obstruction are more likely to be current smokers. They're more likely to have occupations that expose them to environmental exposures with dusty or fume-associated jobs. They're more likely to have comorbidities of metabolic dysfunction and gastroesophageal reflux, and they commonly have symptoms of respiratory symptoms of dyspnea, cough, and sputum production and decreased quality of life. And I think overall their diagnosis can be made by respiratory symptoms, and CT scan, if you do that, can show abnormalities, although I'm not advocating to do a CT scan just to demonstrate this. But if you get it for another reason, they can show increased airway wall thickness, gas trapping, and in some cases, emphysema. So what should be the treatment? Well, one of the things we haven't talked about today is stopping smoking. And if we can't have a respiratory conference anywhere in the world before we highlight the importance of smoking cessation, no matter whatever stage of the disease that you're at, because that not only is the only therapy that prevents the decline in lung function, it's the one that can have an important bearing on the symptoms I just described to you over the last couple minutes. I think overall, most of the studies I've been involved with, we scantily capture some of the environmental exposures, but some of us have patients that are in heavy work environments. There are dusty jobs and have fume exposures, and environmental controls are an important feature of the disease that we should advocate, that we elicit the information for that and help to rectify that in the future. And overall, I think that there is a significant role for alleviating symptoms of airway obstruction and mucus production. There's good literature to show that that not only affects the patient's morbidity, but their outcome. There's data from, again, almost 30 years ago from Jürgen and his colleagues in Copenhagen that showed that those who make more mucus are the ones that are more likely to be hospitalized and are more likely to die from this disease. Thank you very much.
Thank you very much for this very, very interesting presentation, which is now open for the discussion. Just before a minute, because sorry for not having been before, I just have the task also to present my co-chair, Giovanni Pinelli from Modena, who will share the session as a chairman. So, Manuel, first.
Thank you for the presentation. Very interesting. Many years ago, after Neuwenner studied his autopsy lungs in young smokers, we did with Jim Hogg a study of surgical lungs in which we wanted to see if these abnormalities in the small airways could be detected by function using the specific functions of the small airways. You might have seen that paper, and FEV1 and so on. And that was very important because the idea was there at the time that if we can detect these small airways abnormalities, that's the way that COPD starts, according to the ideas then and I think now, we might be able to prevent, these smokers to keep on going and doing this. So the idea is that we correlated the small airways abnormalities with the function, and we found that there was a selected group of people who had smoked less, like these ones, who did have a very abnormal small airways pathology, but had normal FEV1s, like yours. They did have obstruction of the small airways by a small airway test, and they even have VQ abnormalities in the gas exchange. So they were abnormal. They were obstructed of the small airways. So, that they do have obstruction, not FEV1. You said very well, a spirometric obstruction. But they do have. Now, Sonia Buist then took these people, this idea of the small airway disease, and did studies following to see if these people who did have this abnormality in the small airways did go and develop COPD. And they found that they absolutely did not predict anything. They just could not predict it because some of them did, some of them didn't. So these are these people, I think, that you're showing us that we know they have a small airway disease from the beginning, that probably do not progress, but they are symptomatic because they have an obstruction. They have, as you said, residual volume is the main thing that they have, and that's the typical. That's what we found too. That the small airways. So this is interesting. We knew it in a sense. It's nice that we have a population to show it, but this is what happened.
So I guess to complement what you just said, is that the COPD gene cohort is going to be followed for 10 years and hopefully a subgroup to 15 years, and hopefully that will shed more light on whether there is a population that continues to progress and whether you can identify and rectify it.
Yeah, thank you. The next, Bart. And then
Jerry, that was excellent. I'm going to ask you, we arbitrarily decide that normalcy is at 80%. Why don't we raise then and make them abnormal? And move those lines until the people have the same as never smokers, and then that becomes disease.
Well, you sat with the same meeting that I sat in for the last 2 days, and there's a lot of I guess there's a lot of reasons to do what you said, and there's a lot of reasons that are relative why we shouldn't do it. So let's start with the reasons why not to do it. You have this whole body of literature telling us how to treat patients and how they behave with different therapies for decades. That doesn't mean we don't change, but our reference point of who to treat and when to treat would be changed. And one of the dangers would be people would be over-treated with medications. You can imagine that there would be a drive perhaps from some people in industry that this would open up a Pandora's box, that everybody should be on your Lava Lama, Saba Sama, just like you said this morning. So there is a danger that if you open it up that there would be over-treatment. On the other hand, the benefits of showing that this is important, and I agree with what you said, Manuel, that not everybody follows the same monolithic decline, that some people will probably stay at their level forever, and others will show a decline, just was shown earlier with IPF. People will be differently. Maybe the exacerbator group would be the one that declines the most. I think by us not changing the definition a little bit, or at least given some flexibility, we missed the point of the major rectifiable thing, which I think is smoking cessation. And I think if we did that, that would be beneficial by itself, to highlight that these patients aren't normal who are currently smoking, 60% of the population smoking, where we could interfere with that progression of the disease or progression of other diseases as smoking occurs at a younger age. So I didn't answer your
Okay,
question.
next,
But
Leo.
that was
Yeah, I'd like to ask your interpretation of your own data. I maybe call Manuel as well on the discussion. You know, the original thinking, first, it's nice that you corrected it's not gold zero, because gold zero, as it was defined originally, was cough and sputum, which is surprisingly very low in all the groups, it's 15, 20%. So chronic bronchitis is not. CAT 10, CAT has 8 questions: cough, sputum, tightness, dyspnea, and then is fear to go out, problem with sleep, energy. I mean, it's big. Why do I do this? Smoking is not necessarily primarily toxic to the lung. It's a systemic toxic. If you smoke, you get in particles and carbon monoxide after 1 second, in 1 millisecond. So the question is, even with your best approach, in most of these symptomatic people, you find nothing from the CT scan. So you have a large proportion of people who have symptoms, but have really no evidence. And I think, Manuel, that probably also in your study, you have some smokers with normal lung function and nothing in the peripheral airways. So the question is it possible that some of these symptoms are actually related to something else? And yesterday we had a session on micro pathology in each organ, but maybe micropathology in the heart or in the vessels or in the, you know what I mean? I mean, that's actually these symptoms. Then, you know, I know that NIH has sponsored the study on bronchodilators in this kind of, I wonder whether we might have a different approach. We might, you know, treat them maybe anti-inflammatory or maybe aspirin or maybe, you know, ACE inhibitor, I don't know. You know, thinking that they may actually originate from a different mechanism.
Yeah, well, I think that's a good point. You highlight that none of the tests are very good outside of maybe doing an autopsy, which we can't do. But the imaging tests are not that sensitive either. They histopathologically look at what we're doing. The pulmonary function tests are too elite to be able to look at small airways function and too difficult to do in a broad application. But perhaps the future will be is looking at maybe a buccal swab that can be tied to a molecular field of injury. And that may highlight patients that are more likely to have small airways dysfunction at an earlier stage. And then we can look at specific endotypes who may respond more to an anti-inflammatory medication, whatever that is, or those who need a pure bronchodilator or aggregate treatment.
Thank you. We have only time for a very short question, is possible?
So Don Crystal and colleagues has shown that in smokers with a normal spirometry with a reduced diffusion capacity, these were at risk to develop later on than the COPD Gold 1 and further. So do you have these data also in COPD gene on diffusion capacity and the prognostic value of the natural history?
In that cohort, at that time we didn't, but diffusion capacity is being done in the follow-up. So about 60% of this group will eventually have diffusion capacity.
Thank you very much, Jerry.